Welcome to a Longwoods Leadership Discussion. I am Matthew Hart, the CEO for Longwoods. Today we're here to discuss primary care in Ontario, an important but also very large subject. And today we'll be discussing some of those areas. The more resources and tools that we have, the better we are for it. We are joined today by a number of leaders and drivers in the administration and care in primary care in Ontario. But you are not here to listen to me. So to guide you through today, I would now like to hand it over to Dr. Kathy Fauld. Kathy, it's all yours.
Thank you so much, Matt. And I really want to welcome everyone to today's important panel discussion on team-based care for chronic disease management in primary care. We're very grateful to have such a knowledgeable group of panelists with us, each bringing valuable insights to this pressing issue. So their full-time bios are found online on Longwoods, and I'll briefly welcome Dr. Chris Lischka, the CEO of Best Care, a chronic disease delivery program in Ontario, Kim Moran, the CEO of the Ontario Medical Association, Wendy Smith, the Executive Director of Nipissing Wellness Ontario Health Team, and Dr. Elizabeth Mugga, the Senior Clinical Advisor for Primary Care in Ontario Health. As many of you are aware, we're facing a significant challenge in our healthcare system. There's a rising number of patients lacking access to a coordinated healthcare team, which has created gaps in the management of chronic diseases. And at the same time, we're seeing an increasing prevalence of conditions such as COPD, heart failure, diabetes, and hypertension. And these chronic diseases require ongoing management and support, highlighting the priority need for a robust primary care framework. Our hospital systems are becoming increasingly burdened, often overwhelmed by patients who could be better managed in the community. And the situation truly underscores the importance of effective primary care strategies and resourcing that can alleviate pressure on hospitals while providing high-quality care to patients. And compounding all of this is the lack of high-fidelity data from primary care regarding chronic disease management. Without comprehensive and accurate data, it becomes impossible to track outcomes, identify trends, and implement effective interventions. So in our discussions today, we'll explore these critical topics, and I'm going to encourage, just as Matt did, participants attending from all sectors and regions in Ontario and Canada to pose questions, and together we can work towards developing solutions that enhance chronic disease management in primary care, ultimately leading to better health outcomes for our communities. So thank you for joining us today, and let's get started. Dr. Lischka, I'm wondering if you can tell us what are the specific needs of patients living with complex chronic diseases, and how can interprofessional primary care teams play a role?
Well, thank you for the question, Kathy. I want to open to answer your question with some good news. I would like to say that the good news is that we currently have all of the tools that we need to get us along this journey toward improved care for patients and toward health system transformation. We do not need to wait for new medications, for new non-pharmacologic interventions. All of the tools are in the basket. The real challenge is to figure out how we can create innovative solutions to deliver those evidence-based best practices to improve patient outcomes and to improve health system performance. In short, part of that solution is team-based care. We know that when people are managed in a team for complex chronic diseases, they will do better. And we know that health systems that put teams at the foundation, that put primary care at the foundation of the health system, improve. So best care in primary care is one of those innovative models where we are embedding educators, case managers into primary care practices to work side by side with that family physician and nurse practitioner to ensure that every element of best practice is delivered, to ensure patients are living longer, fuller, happier, more active lives. And so Our educator case manager team members are registered nurses, registered respiratory therapists with additional expertise as as educators, as case managers, as guideline implementers, as guideline experts, who working side by side with the primary care doc will deliver every element of evidence-based best practice. And I know that because we measure it in every single encounter. And so by working together, that we'll have patients that will tell us things like, now I can walk for 20 blocks. This program has saved my life. I have never felt my breathing this well in years. And so we have those patient anecdotes as well as proven health system related data to say, yes, we're improving patient outcomes, patient quality of life, but also by implementing those guidelines in a team, by delivering Ontario health program standards consistently and a high level. We're reducing hospitalizations and emergency department visits by 50%, by 70%. So that is what is going to take us on this roadway to a future resilient health system by using team members to support primary care physicians and nurse practitioners to do that very hard work of chronic disease management.
Thanks so much, Dr. Lishka. So Best Care has been, in fact, doing this work in putting interprofessional teams into primary care offices with family physicians and nurse practitioners. So you, in fact, have been delivering on this for quite some time. Dr. Maka, I'd really like to hear from you as the senior clinical advisor for primary care. What specific needs of patients living with complex chronic diseases, and how do you think teams can play a role?
Thanks. Thank you so much, Kathy. And just to the participants, I'm calling in from the Kingston General Hospital, which has a bit of unstable Wi-Fi. I'm from Ottawa, but I'm on site here today. So my apologies if there's a bit of cutting up. So a couple of things. One, I would say I agree with Chris in terms of the optimism about the tools being at hand. At the same time, I think the news about what is coming down the pipeline for us in the health system as it relates to chronic disease is very sobering. The Ontario Hospital Association put out a report just last month that looked ahead to 2040 and identified that in Ontario, we would be moving from what we have now, 1.8 million Ontarians out of 15 living with a major chronic illness, and that's going to go up as high as 3 million. And the call from this report was hospitals can't fix this problem, that we have to turn our attention to prevention and early detection and chronic disease management. And so this is absolutely the work that has to happen in primary care. And what I think patients want from with chronic diseases want from the system is care, number one, that is coordinated. They may have multiple illnesses. They don't want to have to retell their story. They want one record. I think they want timely access to care. They don't want to have to wait months to look after their chronic illnesses. They want somebody who knows them. So a relationship-based care that's centered on who they are as a person and what's important to them. And all of that can be delivered in primary care, but it is absolutely crystal clear right now that we need more than one person, one family doctor or one nurse practitioner alone doing this work, and that an interprofessional team must be part of the solution. And I haven't even touched on the unattached population, who many of whom also, of course, have chronic illnesses. So this enormous demand, let's say, in the system for care of patients with chronic diseases can be met by a team. And maybe I'll just give an example of a patient of mine. I am lucky to work in one of the, there are about 300 teams in Ontario, interprofessional teams that are funded by the government. And I work in one of them. It's called a family health team. And I thought I'd bring my patient, and I'll just call her Susan, who's 67, and she has back pain, chronic back pain. She has depression. She's a smoker. She's diabetic. She's obese. She also is on ODSP, so that's she has challenges around her income. She has past history of trauma. She's a complex patient. I have 15 minutes to look after her in the appointment if it was just left to me. But in my team, I also have a pharmacist who proactively helps me look at her medications, particularly the ones for pain, and helps me manage those. I have a social worker who assisted her with the application for disability supports. I even have a kinesiologist to whom I could send this patient to help her with chair exercises. So all of these services for that patient are wrapped around her in a single team that knows her. So I think, to me, this is the patient story that I think marries some of the programmatic sort of story that Chris just shared about what best care looks like in terms of what it could feel like for a patient to have this kind of team-based care.
Yeah, thank you so much, Dr. Maga. You're talking about this expansive, complex patient, and best care. Chris, you're talking about COPD and heart failure. How do you marry that, Dr. Lishka? Your program is narrow. It's dealing with 2 respiratory or cardiorespiratory illnesses.
Well, I think the way to think about this is to really focus around team and to focus around a repeatable platform. And so while we have focused to start with on heart failure, COPD, and asthma as core diseases, let's put 2 of those diseases at least into a health system context. So in Ontario, every year, there are about 50,000 hospitalizations for heart failure and for COPD. And while we don't address diabetes and some of the other chronic conditions, we're addressing the number 1 and number 2 reason for hospitalizations. The current cost of that is somewhere around $500 million in acute care costs every single year. So those investments are being made. What we're proposing is to say, well, if you have an intervention that you can prove using health system data reduces hospitalizations by 50 or 70%, then you have a program that will pay for itself. And so we took the step of doing a robust health economic analysis with health economists from the University of Ottawa, who concluded that best care was cost effective and dominant. The dominant part means that it's better care at a lower cost by investing upstream in preventive, proactive interventions in primary care with a team. You then can avoid acute care costs, improving patient outcomes, dramatically improving health system performance. That is the roadway to a future resilient health system. And so on that repeatable platform, let's put COPD and heart failure and asthma and atrial fibrillation, our 4 core programs. And then this year, let's add lung cancer screening to that. Again, proactive, preventive, upstream care to improve patient outcomes. And we'll be adding other programs like holistic brain health, dementia prevention as the opportunities arise.
Thanks, Dr. Lishka. I'm going to switch gears for a minute because we're getting into a little bit of that feeling of the tsunami of chronic disease. And Liz, you mentioned that in the OHA, the work with the OHA and the Dalla Lana School of Public Health, and how important that data is to influence us as we look after populations of people. So Kim, I'm going to put you on the hot seat because what are some of the actions or changes, and I'm talking policy, practice, investments, resources needed to achieve this goal of every Ontarian having access to team-based primary care? We know the government has made many significant strides and headways in this, but Liz is sounding the alarm bells for us. So what do you think needs to happen?
Well, we're hearing the alarm bells too, very that OHA paper you referenced, Liz, I think, is not just a call to action. I don't know what you say above a call to action, mandatory. We have to move on these things. And I would say the data that the OMA collects as well is pointing towards a shortage of physicians in every specialty. And really the only answer to all of that is team-based care, right? There really is no other answers, I think, at hand that have shown real promise. Of course, for every physician and every healthcare provider, reducing administrative burden, getting everybody to be able to work on what they're trained to do is important. But today, let's really talk about how we enable that team-based care now. So I think that there's kind of four things I want to talk about. One is expansion of physician-led teams. The second is optimizing those teams to enable enrollment or attachment. Enabling some of the structures we've got in place, like primary care networks, to do the team-based care planning. The last one is lining up our compensation and policy levers to enable all of this, because right now they're sometimes out of harmony. So if I just start about the expansion of physician-led teams, I mean, I think we've seen the government make some really significant investments in team-based care, which we're happy to see. The thing is, we're still only at 30% of Ontarians who have access to a team. So we have to do much better. And those are big numbers for a government to absorb. And, we're all taxpayers, so we understand what that means. But it is about prioritization. And as we know, that I think we all believe firmly that without investing in team-based care, really the future is quite bleak. So I think the need for government to act in this space is critically important. And I will say that we have to sort of, I think, take a wide look of what teams look like, because we've seen many different kinds of teams. We've seen community health centers, we've seen family health teams, we've seen a variety of very innovative solutions in different communities in the North. They've developed interesting ideas. So I think our notion of teams has to be quite wide. And I think we even have to think about how physicians work together as teams. So how walk-in doctors work together with focused practice doctors, with comprehensive longitudinal care doctors. So widening our definition of teams, I think, would be helpful in this. Then on to the second about optimizing the teams to enable enrollment. I think that we've seen where some teams have been quite successful in optimizing enrollment, but it hasn't been consistent throughout. So what is that secret sauce? Liz and I talk about this along many times about how do we enable that? And I think we have to go from sort of the leading practices we've seen and how that, where it works and how we can incentivize that. The next is enabling primary care networks for planning. I mean, we've put these structures in place, and Liz has been very much a part of this. They have such promise, right? And Best Care has played a part in all of that, providing sort of a regional lens on care. I think we need to lean into those structures we've built. The last one is about lining up our compensation and policy levers. As head of the OMA, I see this every day. And I think that there's real importance to do that. So I'll give you an example. For example, physicians are compensated and measured on things as simple as visits, number of visits. But if a physician has a nurse and they're doing care with a patient, that's not counted. So it looks like the doctor's not doing all the work that they actually are doing. And so like things like that, we have to line up in a better way because, when we incentivize our compensation to enable teams, I think that's where we start seeing, those enrollment figures start to climb up.
Thanks so much, Kim. That's a very comprehensive response to what we can do to enable team-based care. Wendy, you're managing executive director of an Ontario health team. And I'm wondering from your perspective, you're the one putting this together, I'll say in the grassroots, right? You're at the coalface trying to pull this all together. What are those things, actions, and changes that you'd like to see that would enable you and empower you to bring about the best primary care team-based care that you can?
So thanks. I appreciate being part of the panel and being able to share some thoughts with everyone today. I just want to open by saying that my thoughts are a reflection of my own personal thinking, and they're informed by my colleagues, other OHT executive directors around the province, our primary care leaders, network leaders, both provincially and within my own OHT. And I don't want people to think that what I say is reflective of the Nipissing Wellness OHT membership in a broader sense. So I want to start by saying that to move forward with this desired state, I propose that we actually need to have a renewed sense of what we mean by the term attachment. In this historical construct, was that continuity of care was only achievable if we had a one-to-one relationship of patient to provider. And is that still our intent as we move forward? Or does our current environment need us to consider that people can be connected to, as Jane Philippot has proposed, a health home or a team of providers that is set up to reflect the needs of a local population? And that many of them may not need one-to-one relationship with a particular individual provider, and many will. And so how might we consider the related definitions of other things like the most responsible provider, and what does access mean? And how might this depend on the geographical location that we're actually speaking of? My experiences working as an allied health provider enables me to say that primary care practice in Northern Ontario and those in Southern Ontario are very much uniquely different practices. And therefore, a one-size-fits-all approach to the future is not necessarily going to meet our goal. My reflection is that a new model of primary care is going to be necessary, that comes with a new compensation model that reflects the current realities of what it means to practice comprehensive primary care in 2024 and beyond. Our historical models and policies that have met the needs in the past are no longer beneficial, and in my belief, actually contributing to some of our current crisis. As we move forward, I strongly recommend that we look to each of Ontario health teams and their respective primary care networks. These local planning entities understand the nuances of their population and have the capacity to engage with their local providers, patients, families, and caregivers, and the broader membership that truly reflects all determinants of health. Collectively, OHTs, in collaboration with provincial partners like Dr. Jane Philippot and those around the table today, have the capacity, knowledge, and skill to inform, design, and implement models of care that will enhance connection to primary care services for all. And I have a few just summarized actions that I really want to put forward. And I'm putting this forward in a sort of macro, meso, micro type approach. So if we think in a macro level, I would suggest that we look at an adoption of a provincial tool or tools that will enable finally us to share care plans and patient data effectively and efficiently between providers. That we enable cross-ministry funding streams to enable OHTs to actually address the determinants of health. That we modernize funding to reflect the needs of primary care teams in Ontario and allow them to remain competitive among other Canadian provinces with respect to attracting and maintaining frontline providers. That we modernize policies. Some of my providers have said that policies such as 50% of providers in a FO need to do hospital care is completely restrictive for locums coming to Northern Ontario who may not have competency in hospital practice. That we shift metrics, as our other colleagues have said, to look at capturing metrics that track our progress towards a quintuple aim rather than just acute care metrics. At the meso level, that we look at cross-sectoral collaboration and continue to encourage this so that we really focus on the needs of the population, and that we develop shared visions and shared goals. And then at the micro level, that we engage with our primary care providers, including all of our allied health members, that we truly empower our patients, and that we continue to build trust and a culture of transparent, honest knowledge exchange across our frontline. So thank you for the opportunity
Wow.
to contribute.
Wendy, that was amazing. I think that I'm listening and I'm going to listen back to this recording because I think that you listing that very, very clearly as someone who's actually doing this in the community is so powerful. So thank you for that. I hope everybody on the line and listening to the webinar is taking that all in. I love the point about making sure that we understand the geography and the population that we're caring for, and what works in downtown London, where I am, is not going to work in Nipissing, perhaps, right? There'll be some standardization. For those of you who know me, I give these analogies, and be prepared, Kim. But if we have a McDonald's in London, Ontario, and I go in and order a Big Mac, I expect if I go to Nipissing, I'll get that same Big Mac. In healthcare, that's not true. Some places you get a tomato, and some places you get an upper bun, and some places you get the full Big Mac. So we have a problem with equity, and you have eloquently given an example of that. So thank you so much. I'm going to move on. You mentioned metrics, so I want to come back to metrics, and I'm going to put Dr. Mugga on the hot seat because having spent years at Health Quality Ontario writing the standards for some of these chronic disease standards, measuring it and knowing if we're there is really significant and important. So, Dr. Mugga, how will we measure the success of team-based primary care models? How will we know that they're working or not working?
Thanks, Kathy, for that question. And absolutely couldn't agree more that we can't improve what we're not measuring. And we have a long way to go in primary care to get to where hospitals are. But that doesn't mean that we haven't started on that path, and that we certainly have the tools to start to build that infrastructure. The first metric I would start with is access. I mean, the reality right now is 25% of the population in Ontario has access to some of these interprofessional team models that we're talking about. That is not okay. So that's the first place to start. And I think what's exciting in Ontario, as many on the call might know, is that we now have this bold mandate that has been given to Jane Philpott that all Ontarians in the next 5 years will have access to primary care supported by a team. So that's where you start. I would then come to what we call tenderly the 4 C's of primary care, because the 4 C's of primary care are where the magic happens in terms of outcomes. And if we don't have those, we're not going to deliver on primary care's promise, whether we're talking about chronic diseases, or we're talking about emergency department avoidance, or we're talking about proper prevention. So number 1 is first contact. I know that's an F, but C is the contact. That basically means access and timely access to care. The next C for comprehensive. So the team is providing a comprehensiveness of care from chronic disease to acute illness to prevention. And also, yes, somebody asked about midwives, prenatal care. So the next is continuity. This is the secret sauce. That's the longitudinal care. That's cradle to grave. That's what makes it different than other types of care like walk-in care. And then the last one is coordination, right? So one person knows that all of this team that's surrounding them has an understanding of what their health issues are, and that there's a single coordinated record for them. After the 4 C's, the very next thing we must do is measure equity, deeply measure equity. We started on that. I think COVID pandemic gave us some really inspiring examples of how we dove into equity to understand how are we doing around access to vaccination. We can do the same thing in primary care across the spectrum of what we do, but that means we have to collect that socio-demographic data and start to look at every single metric from that framing. So where we need to move away from is bean counting. So the sort of old sort of model of like how many visits, let's count those. Those are not the outcomes that matter to patients or that are really going to help us do better. And the last one that I'll just put on the table is I think we also have to measure like the value and the cost, and understand that, so we know primary care overall is underfunded, but we have to start looking at what is an appropriate cost per patient. What does it look like if you're doing it in the north? We know that may be more expensive than it is in the south, but we have to start, looking at some of that costing as well. So, I think the good thing is on the Ontario side, and I can't speak as obviously as well for other provinces, but we are starting to build that infrastructure, to land those indicators, to build teams up to be able to do some of the sociodemographic data collection so that we can move the needle towards better on the measurement side.
Those are fantastic metrics, Liz. Thanks. I'm glad we're getting away from bean counting. That's amazing. And I think what you're talking about with value, return on investment, equity measurement. So Dr. Lishka, Best Care Program, what does it measure? And does it deliver on anything that Liz is looking for at Ontario Health?
Well, I think so. And I do want to also take the opportunity to pick up on a few of the themes that my panelists, co-panelists have raised. Um, and Liz mentions access. And I think, so just share my point of view that on this pathway to enhanced access to team-based care, we need to also be thinking about what are novel models of delivering team-based care. And best care is one of those novel models where it is different than a family health team or a community health center or other models of team-based care, as a very focused implementation strategy for chronic disease management, but embedded in primary care practices. So there may be novel ways of enhancing access. I want to come back really to the question you've asked, though, Kathy, and that relates to what are metrics that we would measure. And I think I have a slightly different approach than Liz. Maybe it's a more frontline approach based on my experience and the best care experience over time. But I'm sort of dividing out performance metrics into two lanes. On one lane, it's very patient focused, and that is what do people need who are suffering from chronic diseases to live longer, happier, fuller, more active lives? What do they need to have preventive, proactive care? And those are metrics that are nicely codified in the Ontario Health Program standards that are part of national and international guidelines and that we have used as the foundation for best care. And I know that we are delivering those in 80% in a majority of patients that we serve. I know that because we measure that performance in every single encounter that we do in primary care practices. But then getting on to the other side, and that is, well, how do you measure things that relate to health system performance? Because that's really also, that's another objective and a goal that we have. And the Institute for Health Innovation, or IHI, tells us that we should be doing those along the quintuple aim. So improving provider experience, improving patient experience with the health system, improving patient outcomes, doing it in a cost-effective way, and also addressing health equity issues. And Liz was getting to that. And so I guess first what I would like to say as a representative from Best Care is very clearly we are delivering on all 5 of those elements of the quintuple aim. I know that because we have peer-reviewed publications where we very clearly outlined that in international journals. Kathy, if I can segue back just to a couple of components, and one component would be around enhancing provider experience, because I think what we really want to do is add value to primary care providers to support a clinical burden that exists as it relates to managing people with chronic disease or with complex chronic disease. And we know from measuring it that we're improving provider experience. And we also know that for best care, 100% of primary care providers that we approach say, yes, we want best care, and then they stay with us. So we're on target to be in the practices of about 20% of comprehensive primary care providers by the end of 2025. And from a cost effectiveness point of view, I mentioned it before, so I don't want to spend much more time on that, but just to say that we have the ability to do robust evaluation using Ontario health system data to clearly identify that we are reducing hospitalizations and emergency department visits while we're improving quality of life. And that allows us to do a robust assessment of health economics, which has led us to the conclusion that we are cost effective and dominant, providing better care in a team environment at actually a lower cost. In Southwestern Ontario, with one final example, Kathy's really over a 3-year interval, we avoided about $30 million in acute care costs and about 25,000 hospital bed days. So that is team-based care with performance metrics measured in action and showing a pathway or an example of how we can transform care in Ontario and across Canada.
Thanks, Chris. I know it's difficult in 3 minutes to describe 15 years of research, but you've done a great job. Wendy, let's move on and we've talked about the best care model. I know that it's not the only innovative care model or team-based care models that are having an impact and that you're utilizing in your Ontario healthcare team. So I'm wondering, how do we work to begin to scale and spread and sustain the models? And maybe you can talk a little bit about the ones you're utilizing and your ideas about scale and spread and sustainability.
Yeah, I'd love to share my thoughts again on such an important topic. And I'm going to reference a couple of models that we've adopted here in the Nipissing Wellness Ontario Health Team, and then reference a model that some of my colleagues have adopted in Southeastern Ontario, which I think is quite timely and quite exciting. So first off, we started our journey in Nipissing by launching one of the integrated care pathways, and we're fortunate enough to get the funding to do so early in the process across the province. And one of the key factors for our success was, in fact, a partnership with Best Care and the team from Best Care. And what we did was we took 2 individuals and shared those 2 FTEs with all of our primary care clinics, which turned all clinics into team-based care for the management of chronic disease. At that time, it was specific to heart failure, but now has been scaled to include the same person provides expert coordination and education to both COPD and heart failure patients across all primary care offices within the Nipissing district. And so that partnership has been incredibly valuable. One of the great metrics that's come out just in the last year within our OHT is that there's been an 86% reduction in hospitalization for heart failure patients. So that is amazing, and that is completely attributed to our providers and our Best Care colleagues that are doing this work on the front line. I have a patient testimonial that says that she wishes that everyone in the province of Ontario had access to someone like the Best Care team member that she has. And that was completely unprovoked. She is just so happy that she has that extra person to talk to. And the providers have been incredibly grateful, because this is adding value, to Chris's point, adding value to their practice. Someone comes in, does a very evidence-based assessment of the patient, provides education, deals with all of the connections to the various different community programs, and then provides very concrete information to the provider so that they can then fill in their piece of the puzzle. And it's just been working very, very, very well. And it's been a key success factor for our OHT overall. So that's one model. The second is that we've adopted the ability to do mobile clinics. So we purchased a vehicle and we've been able, we'll be launching it shortly. Liz is smiling at me. So because we're in a rural Northern Ontario environment, we have a lot of problem with people not being able to get to clinic appointments, and our our ED is the only walk-in clinic. So completely overwhelmed with people with non-emergent issues. So we are going to be using the mobile clinic to go out to more remote areas of the community, and it can be staffed with any organization across our OHT. And then lastly, just want to give a shout out to my colleagues at the in the Kingston area, and the periwinkle model that some of you may have heard has been launched in that area very much aligns with what Dr. Jane Philpott's model is, and this idea of a health home very much in the sort of vision of what it's like to have an educational home as your children grow up. So I think that model, watching watching what happens in the Kingston area with that model will be very exciting.
Thanks so much, Wendy. I appreciate the experience that you bring in working with those three models. And I love hearing about buses, bus rounds is what I call it. We do those in palliative care, and very, very valuable. Kim, I'm going to put you on the hot seat with the same question. What are some examples of innovative care models or team-based care models that are having an impact, and how can we work towards scalability, sustainability of these models?
Well, I think that we have sort of a really good platform for being scalable now, with the government committing that every Ontarian has access to a family doctor. I'm excited about that. And of course, timely access has to come with that. It's not just simply attachment. You know, Wendy mentioned a model that I'm quite excited about, which is the health home model. And I'll just briefly touch on that in a different way. Is that, you know, I think led by Dr. Kim Morrison, who's also the lead in the Frontenac, Lennox, and Addington OHT, really has done something I think quite interesting, which is she said, and apologies for this accounting word, but I am an accountant, assets. She's used all the assets available within that community and tried to bring them together with the bold claim that everyone in that area, every Ontarian will have access to primary care, to a family doctor. And I actually saw a sign on Facebook about this morning to say they were looking for Napanee residents to sign up. And I thought, my goodness, you know, in all this news of patients losing their family doctor, here is a whole innovative group of physicians who are really leading the way in enrollment. So I'm excited about that. And of course, they're bringing together physicians, nurse practitioners, registered practical nurses, RNs, medical secretaries, social workers, mental health counselors, certified diabetes educators, like a whole range of people that make sense for that area. And as we said, you know, making sure that these teams are, I'll use your analogy, Kathy, like the same and also localized is where the magic happens, I think. But I think that they also have access to care coordinators who navigate through our complex healthcare system. You know, this team has a lot of promise. And we're, you know, going back to that other question, which was around what are the enablers of this? What are the levers that have to change? You know, I think that we have to make sure that for physicians, the compensation levers line up with what we're trying to ask them to do. So, you know, measurement of patients who come with five issues. We hear that all the time because it's the most efficient. It's the way patients want, but compensation hasn't kept up with that. The other thing is really about enabling this kind of team-based care to make sure that patients are getting the right health care provider at the right time, and the compensation levers line up with that, because it doesn't really right now. So I think there's a lot of opportunity there that I'm also excited about.
Thanks so much for that. And I appreciate the highlight for the excellent work that Dr. Morrison's doing. That's a fantastic example. I'm going to move to some of the audience questions. And if you have submitted a question and we don't get to it, we do make a commitment to connect you to any one of the panelists. I don't think you guys knew that I was offering this. To have further discussion or to have answering, you know, give some answers to the questions. Kim, you're back on the hot seat because someone is saying you mentioned policy levers for team-based care, and just wondering, can you share what policies we have in Ontario around team-based care, and have any of them been implemented to support, or is this work that we really, it's yet to be done?
Yeah, when I use the word policy, it's actually pretty broad, I would say. And so I think some of the things that have happened are the investments the government's made in team-based care already in different ways, including the recent expressions of interest. We have a lot more to go. I mean, as I mentioned before, we have only, I think less than 30% of Ontarians attached to a team. So there's a lot more investment that has to happen. The other thing is the structures around, say, OHTs and primary care networks. Those structures are really to enable all of that work. So to me, those are very powerful policy levers, and to have the government continue to foster and invest in those is going to be important. As we've seen these early wins coming from this infrastructure. So I think those are the primary policy levers that we see enabling team-based care. But I think we have to dig into more on, how do we have team members working better together? I think that's sort of the thing that we've been wrestling with. That problem is how do we really make sure that we're all lined up so that we can have timely access to the right healthcare provider for the patient's need at the time, making sure that every Ontarian can have a family doctor and a primary care team around them. Like, how do we make that actually on the ground work? I still think that we have some work to do in that space.
No, that's fantastic. That's great. Oh yeah, Liz. Love to have your response
can
to
I
that.
add
You
into this
bet.
excellent question? So
Yeah.
I would absolutely echo what Kim just said around the opportunity on the integration of primary care in Ontario. That's through the Ontario health teams and then their primary care networks. So that is absolutely a policy direction around what is the function of these Ontario health teams and how can they enable a vision of 100% attachment of all Ontarians. So the vertical integration up and down in the system needs to be improved for primary care as well as the horizontal integration. I think there's some policy questions on what's the role of a team. Like, I've worked in a team for a long time. What our team has done is those people who walk in the door are the ones you are looking after. It is a different thing to say the responsibility of a primary care team or home is the geographic neighborhood around them. And that looks different. It's a different skill set. People like Wendy and others, have, mastered this, but we're all in different stages of maturity on that. But I think that's another policy question. Another one I would say, which we haven't yet touched on, is the extended team for primary care. And that was in the chat talking about primary health care. So what are the opportunities around community and social service partnerships? But I would also point out some of our high valued professional colleagues like pharmacists, community paramedicine, midwives. What does it really look like? And these are policy questions to really integrate into a primary healthcare home, some of those other professionals. So those would be just a couple of things to add to what that excellent question and what Kim added.
Excellent. And Wendy, last word on this one. And then Chris, I've got one I want to shoot to you.
Just really quickly, I think the other policy
take
that hasn't been mentioned is that we have to enable all providers to work at their full scope.
Yes. Okay.
Yeah.
That's a great one, Wendy. I think so often the concept of scope is come up and we are set up competing rather than set up to align and collaborate and to have the top of scope practice. And Chris and I talk about scope often. So Chris, I'm sure you're going to weigh in here. Go for it.
Well, I wanted just to follow up a little bit on what some of the other panelists have said, and just to maybe focus for a moment on vertical integration and around the Ontario Health Team opportunity. And so we have this transformation environment that we're working within, and Ontario Health Teams are at the front line of that. And I often use the Nipissing Wellness Ontario Health Team, but as an exemplar of how that is done. But there are many other Ontario Health Teams that we're working with that all have slightly different ideas and that are informing how we build and grow best care. But I value Wendy's participation in the panel and her leadership support in Nipissing Wellness Ontario Health Team, because in the course of just 2 years, I think we have really work together in partnership to help create that primary care network that's animated and active to build part of that integrated care pathway that is so essential for delivering chronic disease management and really supporting that vertical integration between primary care and the only cardiologist in the North Bay region and the 2 respirologists that function there. I think it's that kind of frontline OHT-based leadership that can really help to show the way for how we will get to this future health system that's resilient and sustainable. I couldn't resist, Kathy, just to make a comment about that.
No, I think it's crucial. And there is another question about that, if you want to expand on it a little bit further, which is, as we work on integrating chronic disease, we often face issues with integrating primary care and secondary acute care to ensure a seamless care experience. What advice do the panelists have about how to address this divide? And you've talked also about the HHR issue in the North, and I think you could expand on that in the province. Both you and Wendy could expand on those on that particular question if you'd like to.
Well, maybe I can start and then
Yeah.
Wendy, please jump in. So I guess my thoughts would be, I think there's a recognition that there is limited primary care capacity in general. There's limited team-based capacity. And so we need to look at models that put non-physician, non-nurse practitioner providers working side by side with NPs and physicians to deliver team-based care. There isn't a doubt about that. We also know, and geographically, this is even more relevant in areas like Northern Ontario in rural and remote where there are not so many specialists. We need to make sure that those resources are used as efficiently as possible and for the people that really require specialty care. So by building that strong foundation in primary care, then really only those people that absolutely require specialty practice are being elevated there. And if we used heart failure as an example, just because it's a great Nipissing wellness example, then you can have a cardiologist that's doing an assessment of a patient, but then sharing, say, drug titration and other elements of care with a team-based primary care practitioner, so that there is a clear shared care model. This is what the specialist will do. This is what the primary care team will do. I'm going to hold up there and give others a chance.
Yeah, Wendy, I'd love to hear your answer to this one.
Yeah, there's so much I could say. I don't want to take a lot of time, but I think to some of the things I've seen popping up as Chris was speaking, I found that the most fruitful way to go at this was to really bring the providers together and to have an open, honest conversation and to really focus the conversation on patients. Because we all are our own providers. We all have a skill set. We all have goggles on. We think about what we do and what our scope is, to the earlier comment. But as soon as we think about ourselves as a patient, we can take those hats off and we can think about the patient journey and we can understand what does it actually mean to go to live in this community and have a chronic disease, and what is it that we as partners can contribute to the overall benefit. And as you start to talk in that way, at least within our OHT, we've been very, very lucky to really see that collaboration come together. I don't want to for a second make it sound like it's easy. It's not. But I think you will always have a coalition of the willing who will start. And then once those people start, those leaders can support, the scale and spread of that concept across other groups or other parts of the district. So I'll let Liz tag on to that.
Thanks, Liz. Yeah. And then I've got a question for Kim. We've got 5 minutes left. So Liz, you go, and then I've got one for Kim.
Perfect. I'll just add a 1 minute addition to what Wendy said, which is just the privilege I have of the position of looking across the province and seeing what is happening across the OHTs. We're starting from a place, let's be honest, where primary care has not been held up as an equal partner to other sectors, to the hospital sector. But what I am seeing through these OHTs, through the hard work of relationship building, of culture change, of excellence in leadership, and of some practical projects like the integrated care pathways, is we're starting to turn the conversation around. And, I'll come back to that OHA report, which I thought was really foundational, with the hospitals themselves saying we cannot solve this problem on our own. And the very clear demonstration, I think, across the province as we move forward, the Ontario health teams and primary care networks within them, of starting to see the needle move practically, but also around cultures and values and ways of working with primary care.
Yeah, fantastic. Thanks, Liz. That was an excellent summary for that. Kim, there's a question here. We've got only 4 minutes left, but how does Ontario envision supporting solo practicing community physicians? So those that are in solo practice, fee-for-service or FOS-FIX, they're in their own offices. How do they get connected to primary care interdisciplinary teams? Recognizing, yeah,
sorry.
no, go ahead.
I was just going to say, I think we've seen lots of different models of how that's happening. We've seen primary care networks in their early sort of work has done some of that. We've seen family health teams and community health centers reach out beyond their patients and the doctors that they've been working with to look at all physicians and support all physicians. We've seen hospitals reach out to physicians in their areas to build sort of a system of services. So I think we've seen some of that happening. I think where the question has to go is, how do we do it systematically? I'll use your expression again, so that it's not just a free for all, that it's not just different in every place, but how do we do it systematically so that we're using all these different healthcare professionals in different practice models and optimizing through the system, so that every Ontarian, their patients, can have a team around them. So I think that from the great innovative ideas, now we have to build a system. We have to build sort of the consistency that comes in every single part of Ontario, so we're supporting the doctors who are practicing in those models.
Yeah, and I think really critical that we don't have patients receive treatment based on how their physician is paid, right? That can't be the indicator. So thanks for that. I know Chris would jump on. I know Liz would jump on. I know Wendy would have a lot to say about that. We are at the close of our hour, and I really just want to thank you all for joining today's discussion. We've highlighted the vital role of team-based care. In case you haven't noticed, everybody on this call, all the panelists, are strong supporters of team-based care in improving chronic disease management and ensuring better access to patient outcome. And I also want to emphasize the importance of integrating all of our efforts with the new primary care action team led by Dr. Phil Pott. This initiative aims to ensure all Ontario residents have access to a family doctor or a nurse practitioner. And today the panel emphasized the need for these populations and professionals to be supported and resourced by a team. And one of the models that was mentioned is Best Care. And I've seen lots of questions about, we don't understand what that model is yet. And so if you need more information on it or would like more information, I think we've got a slide up on the screen that you can learn more about it. We've also recognized the necessity of improving data collection in primary care to effectively track and manage chronic disease, and Best Care and other programs do this currently. Other successful models and innovative practices have been mentioned by our panel, and offering really valuable insights into the future scale and spread. Wendy has given us a very good cookbook, as has Kim. So we need to listen to the people that are leading our professional organizations, but also the people that are actually doing this work really, really well in our communities. So levers of implementation are critical and require collaborative efforts by all healthcare sectors. We can't do this alone. We need to work together. And so having said all of that, I want to thank you for attending, and I want to remember to send any outstanding questions to the email that's on the slide that is posted. Thank you once again. We're at 1 o'clock. Have a great afternoon.
Just to quickly say thank you again to everybody who joined. Just to remind you that this will be available on YouTube, and the chat and questions will be forwarded to the speakers at a later date. Thank you. Have a wonderful day. Bye-bye.
Bye-bye.